we were looking at diabetes insipidus. Today we are going to the algorithm approach. So diabetes insipidus basically has got 4 types as we know. CDI, PDDI, and gestogenic diabetes. Today our idea is to separate them in a very specific algorithmic manner. It's an abnormal water metabolism and not due to osmotic diuresis or solutes. That is the basic difference between other conditions of polyuria and diabetes. Other conditions of polyuria, it is usually solute diuresis. As usually it could be sugar or calcium or any other solute like mannitol or anything. Diabetes insipidus can be a very serious condition, particularly brain tumors and all, in the central diabetes insipidus, which is usually secondary. The abrupt onset of polyuria in a patient who is normal otherwise and who has got extremely cold water craving, you can think of diabetes insipidus. Sometimes it is missed for many years, and we have 4 types now. Ways to differentiate: central diabetes insipidus, CDI, nephrogenic diabetes insipidus. PDDI is polydipsic diabetes insipidus. GDI is the gestational diabetes insipidus. So we know out of these, the gestogenic diabetes insipidus is due to vasopressinases, and central is the secretory defect in the hypothalamus and the pituitary, posterior pituitary. Nephrogenic is the kidneys are not responding to ADH, either because of receptor mutation or because of renal disease. Primary polydipsic diabetes insipidus could be dipsogenic, psychogenic, or excessive iatrogenic fluid administration. Okay. So we know already now that the urogenic insipidus is more, and in a very small proportion, around 5% are inherited, 90% are acquired due to brain tumors, trauma, granulomas, meningitis, infections, autoimmunity, and all that, and a small proportion of idiopathy. Here, basically, the AVP production or secretion is not there. It can be partial and it can be complete. Usually, the urine volume is around 8 liters or more. Whereas in nephrogenic diabetes, it is around 4-5 liters. Polydipsia is always an accompanying feature, and the disturbance or injury to hypothalamus or pituitary is the potential cause. Rheumatic, neoplastic, inflammatory, cis, idiopathy. This is vasopressin receptor. Misfolding of the protein, beta receptor mutation is a common cause. Nephrogenic is usually congenital, unlike the other one, where it is mostly acquired. Here it is mostly congenital. There are many mutations of vasopressin gene, and this misfolding of the beta receptor protein makes it located onto the basolateral membrane, and only 10% are acquired. Acquired could be due to hypercalcemia, hypokalemia, bilateral urinary tract obstruction, renal failure, advanced CRF, CKD, lithium therapy. Usually the polyuria is around 4 liters or 5 liters. That is the basic differentiation feature. And there may not be asphyxia also. Whereas in central insipidus, associated polydipsia, large volume of urine, usually acquired is the cause. Here it is mostly congenital is the cause. Polydipsic diabetes insipidus is acquired again, can be due to granulomatous diseases, chronic meningitis, multiple sclerosis, or pathology of the brain, psychiatric illnesses, compulsive water drinking. Gestagenic is placental vasopressin. So when we call polyuria, more than 40 ml per kilogram body weight urine per day is equal to polyuria. So a child of 10 kilograms, 400 ml is polyuria. In an adult of 50 kilos, around 3 liters is the polyuria. Urine osmolality is usually low. Dilute urine, specific gravity is not a good marker. Polydipsia is intake of more than 100 ml per kilogram body weight, which means in a 60 kilogram man, more than 6 liters or more than 7 liters in a 70 kilogram. Measure sodium also on the same day. Now I go to the algorithmic approach. Whatever I did now is only to recap what we have already learned. So what is the step-by-step approach or algorithmic approach? The first and foremost step is collection of urine, 24-hour urine volume. Fluids ad libitum means there is no restriction of fluid. So you will take normal food, normal way he will drink water and fluids. There is no reason to the fluid and as it. So you give a can, a 5 liters can with 10% acetic acid, 10 ml. That can he will keep in his washroom. And when he gets up in the morning, he will discard the morning urine, which is last night's urine. And then from then onwards, whatever urine out is there, it is collected in the can. Next morning urine, you gets up, he has to include that because it is 24. Many people, what they do, last night urine they put, and this night urine also tomorrow morning. So that becomes more. So always tell them, discard your previous day's urine. This day you start, and next day you end with the, including this night's urine, you include. And if necessary, he may have to have a second can also. Because if it is more than 5 liters, you should always give a spare can also. The first step is, what is the urine volume? Is it more than 63 liters or less than 3 liters? In case of children, 40 milligrams per kilogram body weight, per kg body weight. Because children, we don't expect them to pass 3 liters to like depend on the body weight. Now, what are the causes which should less than 3 liters of urine? A patient complains that he has to visit the toilet. That means it is frequency. It is not volume. Then obviously, what are the causes of frequency of urine? The commonest cause is urinary tract infection. Lower urinary tract symptoms will be there, burning will be there, dysuria will be there, pain will be there, frequency will be there, fever may be there. Lower urinary tract symptoms coupled with frequency, you can think of UTI. The second common one in adults is prostate enlargement, benign or malignant enlargement of the prostate, and then frequent urination, but not poly, because it is less than 3. Or urinary tract outflow obstruction by a stone or tumor. Sometimes, in addition to these things, patient may have frequency of urine. Pregnancy itself, they will have frequency of urine, but when you measure, it's less than 3. So, when a patient complains of frequent visit to the toilet, you can suspect polyuria. How do I separate polyuria from other causes? By measuring 24-hour urine. If it is less than 3 liters, I am not dealing with polyuria. I am dealing with other causes of increased frequency of urine. What are those causes? You know, those things you have to diagnose depending on those conditions. Now, The question is, if a person has more than 3 liters of urine, then what is it? Is it diabetes insipidus of any type, or is there any other cause which is causing the more fluid or more urine output for the person? Now, how do I know? Next step is measure the urine osmolality. Osmolality is the concentration of the urine. It is equal to 2 times the sodium plus potassium, and that combined with the glucose, if it is there in the urine, divided by 18. And then instead of 1, you have urea divided by 5.8. With that formula, you will be able to calculate the osmolality. Or give it to the lab, they use an osmometer and measure the osmolality and say this is the osmolality. Normally, our urine osmolality is more than 300, around 500, 600, 700. This is the normal urine osmolality. In this patient, what is the osmolality? If the osmolality is less than 300 milliosmoles per kilogram, it is measured in milliosmoles. If it is less than 300, it means he is passing a very dilute urine. Not only there is large quantity of urine, more than 3 liters, the urine is, quality of the urine is dilute. Why it is dilute? Because water is not reabsorbed. Why? ADH is at fault. The ADH may not be secreted from the pituitary, or kidney is not responding to ADH. One of them. Or ADH is suppressed because of excessive water drink, PPDA, one of these. So it immediately brings me urine osmolality less than 300. I am dealing most likely with any one of the types of polyuria. If the urine osmolality is more than 300 and the patient is passing more than 3 liters, that means there is an excess excretion of solute. Along with the solute, water also is going. That is why urine is concentrated, because of the solute. So what are the common solutes? It could be diabetes, it could be CKD, it could be hypercalcemia, any one of those conditions. If the urine osmolality is more than 300, it is most likely solute diuresis and polyuria, and not polyuria due to ADH problem. Separated. Now we have to evaluate for CKD, we have to evaluate for hypercalcemia, we have to evaluate for diabetes, this patient. And also, the next step would be to do a 12-hour water restriction. What we do is fluid deprivation for 12 hours. That means, earlier what we did while collecting the urine, we said, you take whatever you like, there is no restriction, ad libitum. Now here, you admit the patient at 8 o'clock, into 8 to 8 p.m., 8 a.m. to 8 p.m., no fluid is given either by vein or by mouth. So, normally what should happen when you deprive the fluid, we expect the body to react to the restriction of. Restriction of fluid does what? It increases the concentration of the plasma. Plasma osmolality goes up, ADH will be secreted, and then the ADH will conserve water. Urine osmolality should rise to more than 7. Okay. Now, if the patient, what is this patient? He has got polyuria of more than 3 liters, and his initial urine osmolality or no restriction is more than 300. Then I have given him this deprivation test. This deprivation test has increased his osmolality to more than 750. That means the fluid deprivation acted as a trigger to react with the hypothalamus and to secrete the ADH. Urine osmolality has increased. Okay. It could happen because in compulsive polydipsia also, same thing. He is taking regularly water, more water than what is required, suppressing the ADH. Now I have given him no fluid, so the stimulus for suppression of ADH is removed. Now the ADH is free to act, urine osmolality. or it could be due to other causes also. That means if the patient has polyuria of more than 3 liters and his initial urine osmolality is showing that there is some concentrating power more than 300, on deprivation it has gone to more than 750, this could be a patient of compulsive water drinking, PPDI, or he could be a patient of renal disease or hypercalcemia. How do I separate? Now, at that stage, I look at serum sodium, serum ADH, and renal function. 3 parameters. What is the serum sodium, what is ADH, and what is creatinine, burn, and renal function. Let us say if the renal function is not, serum sodium is decreased and ADH also is decreased, then we are dealing with compulsive water drinking or primary polydipsic diabetes. Why? In compulsive water drinking, he is excessively drinking water, either psychogenic or due to brain infections or anything. This produces dilutional hyponatremia because of excess fluid. That is why his serum sodium is low. And this indirectly suppresses the ADH by feedback suppression because of more fluid due to drinking more fluid. It has suppressed the ADH. So when I started the test, I draw the blood and look at hyponatremia and low ADH, normal renal function, and the urine osmolality at the end of has risen to more than 750. It means this patient is a case of compulsive water drinking. Why? Initially had polyuria, so he qualified for compulsive water drinking. Initially involved urine osmolality is more than 300, so it doesn't seem to be primarily an ADH problem. So already there is some amount of concentration occurring more than 300, and that too when I depends there is responsive pituitary and responsive kidney. Something else is causing other than the pituitary and kidney. That could be renal disease, that could be compulsive water drinking. But then his sodium is low and his ADH is low because dilutional hyponatremia, feedback suppression of the ADH because of excess water intake. Renal function is normal, so it is not renal disease. Now I am in the box of compulsive water drinking. This is how you diagnose compulsive. I am summarizing his features. This patient comes with polyuria, frequency and number of times, and also quantity. I measured 24-hour urine, more than 3 liters. Osmolality, not less than 300. Some concentration is there, more than 300. I deprived the fluid, concentration rose to more than 750. There is some ADH mechanism still intact. I do not know whether it is kidney disease or CWD. I did serum sodium and then ADH, lower, ADH, lower. There is a dilutional hyponatremia. There is a reflex suppression of the ADH because of excess fluid intake. And I looked at the renal function, I have hypercalcemia. I excluded those conditions, confirmed CW. What is the treatment of this fellow? Why do I need to know? I have to restrict the food, not giving vasopressin. He is not a candidate for vasopressin. If there is an underlying cause which is making him drink more fluid, like secondary causes in the brain or psychogenic, they have to be addressed. And restricting the fluid intake for this patient. Now, let us say his sodium is normal, ADH also is normal, there is no dilutional hyponatremia, there is no reflex suppression of ADH, renal function is there. Means we are dealing with acute or chronic renal disease or hypercalcemia. Look at the serum calcium. It could be hypercalcemia along with calcium. Water also is passing. That is why his polyuria is there. He has got more than 3 liters. Initial osmolality more than 300. On water deprivation, it rose to 750. ADH mechanism is intact. There is no suppression of the ADH. There is no dilutional hyponatremia. 1 is raised, creatinine is raised, calcium is there in the urine, calcium is there in the blood, hypercalcemia, hypercalciuria. We are dealing with a of CKD, renal disease or hypercalcemia. Now separate. We are left with two other important conditions. Nephrogenic diabetes insipidus. Secondary nephrogenic diabetes insipidus is here. All the except hypercalcemia, this is all nephrogenic diabetes insipidus only. But secondary due to renal cause, secondary to CKD, the kidney is not able to act properly for the AD. There is some amount. But genetic one is not excluded. Genetic one doesn't behave like that. But 90% of my NDI are genetic. So how do I differentiate? Now we go to the next step of working on. So what is the next one? Osmolarity is increased, all right, but it is not increased to 70 or more. From 300 it has come to 600 or 500, but still it is less than 70. That means, in spite of withholding the fluid for 12 hours, the pituitary kidney axis, ADH axis, is not properly responding. Either it could be pituitary cause, central diabetes insipidus, or it could be genetic cause of nephrogenic diabetes. Now I have to separate these two. How do I do that? I do a test called formal water deprivation test, WDT, water deprivation formal test. What is the difference between this and the previous water deprivation? That was here, we are for 24 hours, we are not giving water. On top of that, we are giving exogenous vasopressin. Now, a chemical vasopressin made in the lab, we are giving. These are the two differences. The earlier one, we don't give any vasopressin. Let us see physiologically what is happening, we have observed. And the restriction is only 12 hours. This 24-hour fluid restriction is a dangerous maneuver, and we may not have food, but water 24 hours, not even drop of liquid, is dangerous. So patient has to be observed every hourly. The sensorium and the sodium levels, electrolyte function has to be observed. Admit the patient and do a formal water deprivation test. This has got two components. One, admission. Two, you monitor the electrolytes and renal function every couple of hours, and also you give him exogenous vasopressin just to see whether the kidney is responding for the exogenous vasopressin. And then in this compulsive water water deprivation test, we have 24-hour period, we restrict the water. Then the result can be two types. One is no response, the other is positive response. What is no response? What is positive response? I will tell you. So who is this patient? This patient is a person who has polyuria, more than 3 liters. He has come with initial osmolality, urine osmolality of more than 300, and on 12-hour restriction, his osmolality increased, but did not increase beyond 750. That is why he has come to this test. So such a patient, I do a formal water deprivation test. So when I 24 hours I deprive water and I give exogenous vasopressin from outside, if it is due to the pituitary deficiency, this exogenous vasopressin will act on the kidney and produce a increase in the osmolality of the urine. Because there is no vasopressin from the pituitary, that is central diabetes insipidus, but I deprived the fluid. On one hand, this fluid deprivation should stimulate the ADH from the posterior pituitary, but it is not secreting, it has not stimulated, but the exogenous vasopressin have given, it has acted and produced the increase in the osmolality. That is a positive response. If it is positive response, it means it is central diabetes, because the in spite of restricting for 24 hours, there is no change in the osmolality. But the moment you vasopressin from outside, this exogenous vasopressin has produced the desired response. And that is why it is central diabetes. We know that central diabetes insipidus, 90% of the times it is secondary. It is not genetic. So immediately I have to do MRI and other imaging modalities to diagnose what is the condition which has caused the central diabetes. Depending on etiology, the treatment will be there. Okay, it is idiopathic or the etiology cannot be removed. It is something which is non-treatable. He has got a brain tumor that cannot be operated. And he has got a idiopathic CDI. The treatment is supplementing the exogenous vascular. This is an ideal candidate because his response will be maximum for the exogenous vascular. Why? What is not there from the pituitary that we are giving from outside. Like when pancreas is not having insulin, we are giving insulin. Likewise, in posterior pituitary is not secreting ADH, we are now giving the ADH from outside. And the treatment is not fluid restriction, but giving him the exogenous vascular and evaluating the underlying cause and then treating the underlying cause. Okay. Now, if there is no response means in spite of giving exogenous vasopressin, urine osmolarity continues to be less than 750 only. It has not increased. That means already there is pituitary vasopressin also in the body. So that is the kidney is not responding. Now you are given exogenous. So this also it is not responding. You used all the methods. Originally there is pituitary vasopressin. On top of it, you waited for 12 hours water deprivation. That did not produce increase. 24 hours also you gave. That means whatever is there in the pituitary, it has already come out to the kidney to act. And also I have given from outside, that also went there to the kidney. Kidney says, no, I don't want to respond to the ADH because of receptor mutation or due to any genetic cause. Non-response to WBT is nephrogenic diabetes. Gestogenic diabetes insipidus is easy to diagnose. Patient is having polyuria, more than 3 liters, osmolarity of urine less than 300, no test required, no water deprivation should be done for pregnant women, no formal WBT, no 12-hour WBT. The moment she is pregnant and she is polyuric, urine is dilute, it confirms it is vasopressinase-induced pregnancy diabetes, which is self-limited and you don't require to do anything. You don't have to give exogenous vasopressin also because even whatever you give from outside, that also will be destroyed by the only thing is ask her to match the fluid intake and then maintain until the pregnancy. By third trimester, it will come down. After the placenta is extruded, after childbirth, the condition stops. It doesn't progress into diabetes insipidus, just like other diabetes. So pregnancy diabetes is removed. Then in the previous slide, we have compulsive water drinking. We have diagnosed the treatment, fluid restriction, and not giving exogenous vascular. For central diabetes insipidus, the WDT will be positive. Evaluation is very important. Most of the time it is secondary. Secondary causes have to be treated and exogenous supplementation of vasopressin has to be given because 8 liters, 10 liters is a cumbersome business. The moment you put him on treatment, his urine volume will come down, his quality of life will improve. For nephrogenic diabetes insipidus, usually it is genetic, very small proportion of acquired. They don't respond to exogenous vasopressin as the other group, the CDI, respond. But however, you can still try to reduce the symptoms and reduce the urine output. Some amount of action may be there. You can give exogenous vasopressin, but it is not usually very effective. Then who are these people? Mostly they are children. These children will not be able to complain that they have polyuria, thirst, and all that. Usually failure to thrive, genetic causes, if they are there, some of them may not survive even the first year. It may be a very killer disease also. Nephrogenic diabetes insipidus. Okay, in the previous, if it's renal failure, give some dialysis or peritoneal dialysis, or think about renal transplant, other causes, hypercalcemia, you treat the response. That is secondary nephrogenic diabetes. Require congenital and NDI will not respond, will not have any underlying cause to remove. Genetic cause cannot be treated. Little vasopressin may be helpful, but usually they have problems. Okay. Now, this is algorithmically, we have differentiated polyuria from frequency first. Then among the polyuria, those with solute excess more than 300, less than 300, those who are really polyuric with osmolar urine, they have identified solute excess, we know diabetes, hypercalcemia, or any other solute, found out and treated. Those with frequency, we have found out low urinary tract symptoms, obstructive uropathy, prostate enlargement, pregnancy, those. Now we have got a group of people who had the normal urinary function, renal parameters, in sodium and ADH, their compulsive water drinkers, their osmolarity rose more than 750. And that group has to be treated with water restriction. Whereas the osmolarity raises on 12-hour water deprivation to more than 750. But the renal function is abnormal, sodium and ADH are normal. You treat identify the renal disease, treat the renal disease, and hyper. When you come to the group where there is no increase in the osmolarity beyond 750, did a formal water deprivation. Those who are negative, they are nephrogenic. Those who are positive, they are WBD. Here is vasopressin. And the kidneys are responsive. Pituitary is not secreting because the kidney mechanism is intact. The excess vasopressin has acted. That is the way there is a positive response. And here, mostly they are do an MRI or imaging, evaluate the cause. Exogenous vasopressin will be highly useful in these cases. Whereas the nephrogenic diabetes insipidus, pituitary ADH, it is not responding. Water deprivation also, it is not responding. Formal water deprivation test also did not work. Exogenous vasopressin also did not work. That means there is a genetic block at the kidney level which is not allowing the ADH to. Those cases are difficult to treat, they survive, they only require exogenous vasopressin. For whatever it is, it is you give it, then give it a try. Usually these are children. Now, here also called the formal water deprivation test. Indication is to evaluate diabetes. Okay, technique is complete fluid deprivation or inject hypertonic sodium chloride. Fluid deprivation does what? Concentrates the plasma. You give hypertonic saline, it also acts as a stimulus. Generally preferable to give fluid deprivation rather than hypertonic sodium chloride. Because we know hypertonic sodium chloride has got its own problems. We don't want to simply use hypertonic sodium chloride. So, injection of DDAVP exogenously you give. How much you give, I'll show in the next. Measure ADH to serum osmolarity ratio. What we do? We measure the ADH and also measure the serum osmolarity ratio. That is ADH in the plasma by urine osmolarity. Serum osmolarity. Serum osmolarity, how to measure, you know. Okay? Interpretation of ADH to serum osmolarity ratio, positive or negative. A decrease in the ratio means what? Decrease in the ratio means that serum osmolarity has increased. Isn't it? Serum osmolarity increases, the ratio will come down. ADH by serum osmolarity, let us say ADH is 4 units, serum osmolarity is 290, 280 normal. Now, if the serum osmolarity has increased because of the test by 290 or 200, then naturally the ratio will become less. If the ratio is less, it means it is central diabetes insipidus. If the ratio is more, that means serum osmolarity has changed. Given no change, is more, that is the nephrogenic diabetes. Okay. Now, what is DDAVP, AVP, and oxygen? These three are almost similar molecules. AVP is arginine vasopressin. DDAVP is a synthetic vasopressin. Oxytocin is the one which acts on the uterus and the obstetricians use. It also raises the blood pressure. Look at the chemical structure. AVP has got a amino terminal, cysteine, tyrosine, phenylalanine, glycine, aspartame, cysteine, proline, leucine, and then, not leucine, L-arginine, glycine, and amino terminal. Now, if you see this amino terminal is missing, there is no amino terminal, cysteine is cysteine, tyrosine is tyrosine, phenylalanine is phenylalanine, glycine is glycine, aspartate, cysteine is again cysteine, proline is proline. Instead of L-arginine, levorotatory arginine, we have a dextrorotatory arginine incorporated in that place. That is why it's called D-arginine vasopressin. Normal one is arginine vasopressin because arginine is the central molecule, arginine vasopressin. It is D-arginine. Where is it? D-arginine position 1, 2, 3, 4, 5, 6, 7, 8. In the 8th position, D-arginine. That is why it is called 8-D-arginine phosphate. What is this one at the first position, the amino acid is removed. Des amino, no amino in the first position. So 1 des amino, 8-D-arginine is called desmopressin or DDA. Oxytocin, you see, it is exactly mimicking AVP, nitrogen terminal, cysteine, tyrosine, glycine, aspartame, cysteine, proline, L-leucine, and leucine are the two names. Phenylalanine, L-leucine, L-arginine is there. These two amino acids make it a different form. This is also coming from the posterior pituitary. In pregnant women, the time of childbirth, the oxytocin level suddenly increase and there will be an expulsion of the fetus. And if the woman is not able to deliver, then exogenous oxytocin injection also is used. Oxytocin and vasopressin share the same clinical structure except two substitutions. Phenylalanine is written as isoleucine, L-arginine is written as L-leucine. Other than that, this is a bit of theory part. Now, DDAVP, you must know a little about this drug, desmopressin, or 1-desamino 8-D-arginine, DDAVP. Several formulations are available: intranasal drops, nasal spray, parenteral, oral. All four are available. The commonly used one is spray or tab. Parenterally generally not required. Why? Because this injection has to be given every day and because life nutrition is required, just like insulin. When oral formulations are available, nasal spray is available, why should you give injection? So unless there is an acute, and this is a chronic disease, there is an acute need, then you can use parenteral formulation. Otherwise, parenteral formulation is not used. What is the strength? 4 micrograms per ml is the parenteral. Intranasal solution, 100 micrograms per ml. Intranasal spray, 10 micrograms per ml. Spray has got a small, 10 micrograms per spray. So each spray contains 10 micrograms, whereas 1 ml of the solution used as drops contains 100 micrograms. Orally, 200 microgram tablets are available, and these 200 microgram oral tablets are 10 micrograms of intranasal solution, intranasal spray, 20 micrograms, so 200 micrograms oral is equal to 10 micrograms. The dose is usually 200 micrograms orally Twice a day is the dose. Or you use in the nose intranasal spray of 10 mcg morning and night. Desmopressin spray, DDAVP spray. There's one condition, you may get the short notes, nocturnal polyuria. It's not polyuria, it is called nocturnal polyuria. You may get a short notes. Now, normally what happens, circadian rhythm for the AVP. ADH has got a circadian rhythm. All of us know that during daytime, we visit the washroom at least 4 or 5 times. In the night, once or none. How this is a beautiful inbuilt mechanism. Otherwise, if we were to pass 5 times urine in the night, sleep will be disturbed. So, to avoid that, the inbuilt mechanism by the biology itself, by God itself, created in such a way that daytime you have more urine output, nighttime you have less urine output. Less urine output means what? There is anti-diuresis. Anti-diuresis is less urine output, no more urine output, no anti-diuresis. Anti-diuresis you want, you require more ADH in the night, less ADH in the day. So the secretion of ADH is antidiuretic hormone secretion is minimal in the day and maximal in the night. With the result, the circadian rhythm is maintained. People you will not have to urinate in the night more number of times. Now, in nocturnal polyuria, what happens? The circadian rhythm is disturbed and the ADH is not there even in the night. When ADH is not there, what will happen? There will be diuresis. He has to go more now. This is a disturbance in the circadian rhythm of the ADH. What is the circadian rhythm? Daily, in every normal individual, during the day hour, the ADH is low, so that the urine volume is more. In the night, the ADH is high, so that the urine is concentrated and urine volume is less. The morning you go, you see urine is concentrated, light yellowish color. Daytime you pass, urine is less concentrated, almost like water. So you all observe. This circadian rhythm is disturbed in case of nocturnal polyuria. Okay, how do I diagnose this condition? I have to measure plasma AVP and urinary AVP. Okay, 24 o'clock. And then we have to buy urine AVP and urine creatinine ratio. We have to. 3 tests are required. Plasma AVP is required, urinary AVP is required, and then urinary AVP, 24-hour collection, creatinine also 24 hours. So you obtain a ratio of urine AVP to urine creatinine. Normally, the urine AVP should be more in the night. In these people, there is no AVP. So naturally, there is diuresis in the night. How we did that? That's how we diagnose the condition. So there is no specific treatment for this condition because only thing is the restriction of fluids to some extent in the night after 6 o'clock or 5 o'clock might work to some extent to reduce their body. Now, what are the take-home messages as far as the polyuria or diabetes insipidus lecture is concerned? AVP or ADH is from the neurohypophysis. This ADP or AVH will act on the kidney, on the collecting duct and the convoluted tubule to conserve water and water reabsorption. So that is, there is a pituitary mechanism, there is a renal mechanism. Both should be intact to produce a normal physiology. Patient with central diabetes insipidus, the pituitary secretion is at fault. In patient with nephrogenic diabetes insipidus, the renal handling of the ADH is at fault. Usually pituitary causes are secondary and genetic causes are only 10%. Whereas kidney causes are basically genetic and only 10% are secondary. So polyuria will have multiple causes. Renal handling of the water homeostasis is maintained by aquaporin channels. The proximal convoluted tubule and the descending limb of the loop of Henry absorb around 70% of water. There, no ADH is required, and this aquaporin one channel will act. Whereas when you come to collecting duct and DCT, The ADH influences the absorption of water by aquaporin 2, 3, and 4, basically aquaporin 2 channels. And there is a AVP receptor. This receptor mutation can produce nephrogenic diabetes. CDI, NDI, VDI, GDI are the 4 different types of diabetes. Mainly CDI is acquired and NDI is the algorithmic approach we have seen 24-hour. You look at, is it less than 300 or more than 300? Is it less than 3 liters or more than 3 liters first of all? Then is it less than 300 urine osmolality or more than 300? If it is more than 300, it is solute diuresis. Less than 300, 12-hour water deprivation should increase to more than 750. If it is increasing, then how is the renal function? Normal, sodium less, ADH less, it is compulsive water. Renal function abnormal, sodium and ADH are normal, then it is chronic renal disease or renal causes of polyuria or hypertension. Then you person did not increase up to 750 after 12-hour deprivation, then you do a formal deprivation, then you have a positive response, then negative. Positive responders are cerebral cause, that is the pituitary cause. Negative response, the nephrogenic. Treatment, supplementation is the treatment for CDI. Supplementation may or vasopressin in compulsive water, only fluid. Okay. DDAV replacement is required in CDI. It may work in NDI. So these are the take-home points as far as the diabetes insipidus is concerned. Now, if you have any doubt, you can ask how to differentiate the various types of polyuria and this particular diabetes. And the questions, multiple choice questions, if you are attempting animal, it will come like this. They will give the urine volume for 24-hour urine volume is this much, urine osmolality is this much, 12-hour deprivation did not increase, sodium is like this, potassium, H is like that. What is your diet? So you have to work using these things. This is a book chapter in a textbook of medicine written by me. So look at that, and in the website available. Anyway, I'm giving the video and PPT also. Last week video I have given. This week video also I will give. Now the most important part is water is the immortal fluid, and that water is conservation of water, both by the body and in the environment also. Conserving water is very, very important. There is an important Upanishadic mantra which says, Yo apam pushpam veda pushpavan prajavan pasuman bhavati. Means what? The one who conserves water, who understands the importance of water, he will be blessed with all prosperity. Because they know water is such an important fluid to conserve. And those who conserve water will be blessed with pushpavan, very flowery. Prajavan will have children and progeny. And then pasuman will have a lot of cattle and riches and wealth. So if you want to be blessed with good hair, progeny, and you want to prosper, you better learn to conserve water. That is what that Upanishad mantra in Yajurveda 5,000 or more years back. That is more applicable even today. If we don't take care of water, our next generation may not have even a drop of water to drink. Any planet, the first thing they look for is there water on the planet. If there is water, there will be life. If there is no water, there is no possibility. So that is why it is called Amrita. Amrita means not some drink the Devas drink in the heaven or something like that. It's a misconception. Amrita is what you are drinking. Mrita is death. Amrita is no death. So this is the one which gives me no death and life. This is the fluid of life, Amrita. So with this we will close this talk. Thank you for your attention.